Hello, my name is Stresthley. I'm a co-worker in DR Congo. Welcome to CMN 2020. I've been asked to speak to you about the work of the church and the work that I've been doing in COVID-19, and specifically looking at how it compares to what happened in the US. As a health professional, this has been really interesting to dig into what happened in Congo and compare it to another country. A lot of things haven't gone well in Congo, but from the looks of it, what they've done with COVID-19 has been pretty impressive. In dealing with the pandemic, the guidelines for addressing that pandemic are pretty similar throughout the world. So it's not too hard to compare what happened in Congo to what happened in the US. Here are the key statistics for the pandemic. The first numbers are the total numbers as of September 8th. But I think what's more interesting is to look at the cases, at the numbers that are compared to 100,000 population. There we see that the US has about 2,000 cases per 100,000 population, and Congo only has 12. Now, there's probably a lot of underreporting in both countries. I've seen some articles saying that in the US it's about 10-1, that they're only catching about 10% of the cases. Congo, maybe you can compare it to what's going on in India, where it's about 30-1. But even if you look at those missing data, it's still a huge difference between what happened in the US and what happened in Congo. On the deaths, the US had 59 per 100,000. In Congo, it had 0.13 deaths per 100,000. The death rate was about the same in the US and in Congo. And that would make an argument that maybe we're not missing as much in Congo as we assume. Here are the measures that we need to take to control COVID-19. These are the guidelines that are out there. Now, there's probably a different list, but this is the one that I put together from looking at multiple sources. So it's pretty universally accepted that you need to wear a mask and social distance as long as the pandemic is going on. Avoid large gatherings. Avoid interacting with others in closed spaces. And the guidelines for starting lockdown. I'm surprised that this is not more publicized, but it is quite available if you look for it. Basically, what they're saying is that if you have 1 death per million population, you need to be going into lockdown. So this is something that you would come and go from as the pandemic progresses. To test whether you can come out of lockdown, you have to depend on the positive testing rate. But that is only accurate if you're doing about 150 tests per 100,000 population per day. So if you are doing that number of testing, then you should stay in lockdown until you start seeing a 2-week reduction in the numbers of new cases, and the total number of positive cases is only about 5% or less. So how did the US and DRC compare on this? So with the masks and social distancing, it's hard for me to say exactly what's happening in America because I'm far away from it. But from what I see in the news, it looks like it's been pretty inconsistent in applying that policy. Some places apply it, others don't. It's become very political. In Congo, it's a very clear message. It's mandatory to wear a mask in public, and it's enforced with a fine. But still you see people on the street not wearing masks but it's rare to be inside of a store or any building and not see people wearing masks. The indoor gathering. Again, sometimes it seems like in the US it's discouraged but not outlawed. Other times it seems to be outlawed, but it's often not followed. And there's been these very large rallies and events that have kind of been super spreaders. In Congo, on the other hand, when they put out the order that no meetings or no gatherings of more than 20 people, it was surprising how well that was respected. For 4 months, you didn't hear churches going on, you didn't hear bars going on. I was really quite surprised at how universally that was accepted. I was not expecting that. So for starting the lockdown, using this 1 death per million population guide, only 15 states applied that correctly in the US. The rest delayed by sometimes only 2 to 4 days, sometimes for weeks. I think the average for, well, there was a difference between Democratic and Republican run states, but the longer one was for almost 3 weeks before applying that. Whereas in Congo, even though we never reached 1 death per million, even if you look at just the population of Kinshasa, where most of the cases were, they locked down and they stayed locked down for 4 months. On testing, neither country did well. The US took 2.5 months to get up to the level that was considered sufficient, and that, from what I can gather, again, was sporadic. Some places had it, some places did not. In Congo, it was never achieved. There was never enough testing going on to really know what was going on. And then for ending lockdown, it seemed that in the US, there was a lot of pressure to end lockdown quickly. So even though the guidelines were out there, people rushed through those guidelines. I saw that in some states, even though the testing rates were above 20%, they were still getting out of lockdown, whereas they should have been staying on until they had gotten those positive tests down. In Congo, because we weren't doing enough testing, the positive tests did go down, went down to about 8%, and never reached the 5%. But for a full month, in fact, over a month, the number of cases consistently went down before they left lockdown. The video I'm about to show you is from an interview that I did of Mano Tangani. Mano has worked with me for about 15 years. He's very good with his relationships with the government, and so he is the director of health system strengthening within IMA World Health. When COVID-19 came on, we assigned him to be the director of that program, so he's been managing that for the last 4 months. What did the government do to address COVID-19 in Congo?
Okay, thank you very much, Dr. Larry. The government of the Democratic Republic of Congo was informed that COVID cases were coming up from China, but it wasn't until March 10th that the government get involved here in Congo, as the first case was confirmed in Kinshasa. So what they did basically was to set up a task force around the president and a national committee, multi-sectoral committee around the Prime Minister and the Minister of Health. And at the coordination level, they have to put a commission, a response commission that was led by the Dr. Muyembe, which worked closely around the INEAB, which is the National Institute for Biological Research. So that was the main step that the government take, but this technical committee around Dr. Muyembe has the mission to set up a national response plan, which was articulated in 9 commission or objectives, if you want. The first one was to set up a governance system that should help in the coordination of all the country effort in trying to stop COVID. The second one was to make sure that there is a sound treatment procedure that is in place to take care of all the patients that were being diagnosed. And the third one was to put in place a system where the diagnosis can be done correctly. So they have to train lab and make sure that they are train diagnostic kits in the country to do the testing. And the second one was to make sure that infection is controlled in all the air facilities, particularly to avoid that health worker can get easily contaminated. So they have to put in place a measure on infection and control to prevent that. The other one was to set up a system to improve risk communication and community engagement, so people are aware of the risk of getting the diseases and they act appropriately. They also set up a group to supervise all the coordination effort around surveillance and case tracking, which was really important. In addition, they also set up a commission to do all the logistics, because logistics is very important in emergency situation.
Here's the timeline of the controls that were put in place in Congo. So starting on March 10th, that's when the first case came in. Within 9 days, the government had put out a mandate that no gatherings of over 20 people, churches, schools, sit-down restaurants were all closed, and incoming flights from maybe 8 countries, these were Asian and a few European countries, required quarantine for 14 days. But Inge and I went to South Africa in February, even before this was happening. And when we came back, they checked our temperature on the tarmac right as we got off the plane. So you could not even get on the bus to go to the terminal until you were cleared. I know that, they were very used to doing this because this is the same procedures we had in place for Ebola. But as soon as Congo started hearing that there might be something out there, they applied that to every flight coming in. By March 23rd, so 4 days later, all international flights were banned. And coming and going from Kinshasa required special approval. The rest of the country, people can move around. By April 6th, there was obviously a concentration of cases in the Gombe area, which is the downtown region of Kinshasa. And so they put that whole region, or that whole district, into confinement. You could not come or go from that without a pass from the INRB, which is kind of like the CDC of Congo. This scale is not proportional. That shutdown of Gombe lasted for 2.5 months before they opened it up. And when they did open it up, they allowed businesses to start up again if they were essential. A month later, they opened up banks and restaurants and bars. On August 3rd, they opened up schools, and then by August 15th, they opened up the airport again for international flights and domestic flights. Also, churches started meeting again after August 15th. So this is what it looked like as far as the number of cases and where they were on April 6th when they shut down Gombe. And you can see that 64, I think probably out of maybe 100 or so about half of the cases were in that one Gombe area, and that's why they shut it down. I had a pass to get into Gombe because my office is within the Gombe area. And I had to be going to meetings with the government during that time. So this is what we went through whenever we went. I still only went maybe once every 2 weeks through this barrier. But you had to get out of your car, show your pass, get your temperature taken, wash your hands, get back in the car, and be led through. Because of these strict measures, this is what was achieved in Congo. You can see that there was a spike, around June, July, and it's been consistently going down ever since. The blue is the Kinshasa area, so you can see predominantly all the cases, or most of the cases, were in Kinshasa. And the yellow that you see over to the right, that's North Kivu. So that's been where the newer cases have been. For the last 3 weeks to a month, Kinshasa has had an average of less than 10 cases per day. This is where we are today. There's 10,000 cases. Only 2,262 are outside of Kinshasa. And officially, there's 262 deaths. There's probably more deaths than that. But when we look at national statistics coming through the hospitals and other sources, there hasn't really been a big spike in deaths. And so this is not too far off from what really happened. Something that's kind of amazing is that there's 96% of the cases are being contact tracked, meaning that the list of the people that they have come in contact with for the last 2 weeks is being registered, and those people are being followed up with. Like I said, the testing is low. It's only about 377 per day, but the overall positive rate is down to about 8.5 now. As is the case throughout the world, it's the elderly that are dying the most. So about 9% of the cases coming in are over 65. But 36% of the deaths are of that age group. And those that are dying, as in the rest of the world, have complications of hypertension and diabetes, for the most part. So what did we do, IMA World Health, working along with the church to address COVID? After being contacted by DFID, we wrote a proposal and we got $6 million of funding from UKAid to respond to COVID-19, mostly in Kinshasa. About $5 million of that is in Kinshasa, and the rest is for Kasai Central and Nord Ubangi, other provinces that we work in with other projects. For the Kinshasa work, we contacted 3 church groups: the ECC, which is what the Presbyterian Church is a member of, ADRA, and Salvation Army. These were chosen because they have about half of the healthcare system of Congo is delivered by church groups. And these are the groups that are most active in Kinshasa. We did training, we rehabilitated some health facilities, we supplied personal protection equipment and other equipment so that about 186 health facilities could respond effectively to COVID-19. This is a picture of training the community volunteers. Every health facility in Congo has 20 to 60 volunteers that work with them. And so there are an army of people that will help with vaccinations, with nutrition programs. But when COVID came along, they were the ones that were recruited to do the messaging to the population. They took the message down into the homes, explaining what people needed to do. They had megaphones and they went through the streets, giving the message. For about 3 or 4 months in Congo, every time you made a phone call, you didn't hear a ring on the other side. You got a COVID message. It got quite annoying after a while, but it made it so that every day most people heard the message over and over and over again, and knew exactly what they needed to be doing. Here's one of the hospital wards in Kimbanseki that was rehabilitated with the money from UK aid. One of the more exciting parts of the project was to connect with church groups, or women's groups mostly, to make masks, because the surgical masks, one, they were restricted. Both the US government and the United Kingdom put restrictions on us buying surgical masks because they were needed for the health personnel. So there was a lot of pressure to make masks and get them out to the population. One of the groups is the CPK. You see Mama Masenga next to Christy Boyd. So she mobilized her team. And to the left is a Subco Baptist missionary and the head of the women's department for the Baptist church. And then there was a smaller group called Tabitha, which independent church. But these 3 groups made 100,000 masks in 45 days. And now we've given them a second contract for another 75,000 masks that they're going to make in September. Another part of the message is washing your hands frequently. And so part of the project was to fabricate out of metal, construction metal, 550 hand washing stations. And these were distributed along with cleaning supplies and personal protection equipment into health facilities and a few churches. This is at a health facility, and you can see the checking of the temperature using the flashed thermometer and the hand washing. But it's throughout the city. You cannot go into any public building, whether it be an office building or a grocery store, the government building. Everywhere requires you to have your temperature taken, to wash your hands, and to wear your mask when you're inside. We avoid going out as much as possible, but it's reassuring that when we do go grocery shopping, everybody is abiding by these rules. I think the question everyone has is, were the public health measures that the Congo government put in place sufficient to make the low case rate and the low deaths, or is there something else going on? I asked Bono this question, and this is his response.
There are many opinions on that. Some people think that Congo has been underreported. As you just learned from India. So in India, they are talking about, for one case reported, there were about 83 to 130 cases underreported. So this brings up a total number of millions in India now, which is, I think, the second or the third leading country in terms of cases. But the case of Congo actually is a little bit, I would say, strange, because you don't see a lot of death. So it can suggest that there are very few cases compared to other countries. But I would say ecological, the environment of Congo, and may have played a big role here in making that very few people get sick here. This is one part. But the other part is that some health prevention activity that promoted hand washing system here in Congo, with almost every facility, restaurant, church, with hand washing system, also created a setup that people can easily understand the risk and quickly change their behavior to avoid transmission. I think that plays a lot. A project like SSR, project like Sandru, in the past, I would say 20 years from now, have worked a lot in teaching people how to wash their hands before in critical moments, like before, after coming to the toilet, before eating. All this, I think, have played a big role in educating people to avoid getting the diseases. But we have to say that God has played a big role as well, protecting the people of Congo, given the fact that we have problem with the infrastructure in Congo. There are very few. For the whole country, I'll say we have less than 100 ventilators. So if we have to have severe cases of COVID, it will be very difficult to handle that. So I'll say this is on the place.
Okay. Is there anything you want to add?
Yes, I would like to thank all the church groups that have been involved in Congo, and it's important that this support continue in the future, because missionary around here and church group around here are very supporting the health system in Congo. And I have a few examples. One of the church in Gili, actually, we have a project we are rehabilitating the hospital that is in this church, actually, is supporting even people who are poor, who can't afford to pay health care. So they're putting people first, not money as other public or private health facilities are doing. So it's best that those churches that have program be supported to continue to support the people in Congo, most of whom are still poor. Thank you.
Okay, thank you.
So there's differing opinions as to why Congo did better, but this is my list of why I think Congo has done better than other countries in keeping their cases low and their deaths low. The first is what I've been talking about here, which is that they applied and followed public health guidelines better than most countries. Second thing is the age distribution of the population. 46% of the population is less than 15 years old, so most of them are asymptomatic. There's only 2.7% that are over 65 in this high-risk group. And as you remember from the graph I showed before, 9% of this group was the total number of patients of new cases. So they were heavily hit. It was obviously more in the older crowd, and they died off more. But there's so few of them, it would have been much worse if there'd been more in that age group. And as I mentioned earlier as well, Congo has this long history of contact tracing for Ebola. And so these relays that we used, they've all been trained in this before. So it's just a refresher course, and they could apply what they learned before for this new disease. And that's made it so that even though there's not much testing going on, the testing is targeted for the people that were most likely come down with the disease. After that, we're getting much more speculative. But an observation I made is that and all of you that have visited Congo can attest to this, that almost all socialization in Congo happens outside or in the church building or a gathering like that. So when those large gatherings were outlawed, most of the interaction with people that you would be getting COVID from was in the open air. And the literature is pretty clear that you're much more likely to have a low exposure if your first encounter with COVID is outside as opposed to inside. It's a dose-dependent disease, so the less you get a dose of it, the less severe you will have the disease. So both mask wearing and interactions outside will make it so that a large proportion of the population has been exposed, but they were probably asymptomatic. I have an anecdotal example of this. A company that we associate with, we rent our office space from them. They decided to test every one of their workers. So from the CEO all the way down to the night watchman, they tested their population, their staff. And even though this was done back in April, so before the spike, 20% of their staff were positive, but they were all asymptomatic. So if that is representative at all of what's going on in the population, it supports the idea that there has been more exposure, but much of it is asymptomatic exposure, either because of the dose or the age of the people that are being exposed. You'll also see articles out there trying to figure out why Africa in general is having lower caseloads and lower deaths. And one theory that's put out is that because of all the disease that people have to face on a regular basis in Congo and throughout Africa, and the fact that vaccination coverage is much higher here in Africa than it is in Europe or the US, that there's probably some immunity already in the population for a lot of diseases, and COVID might be one of them. Now, this might be a partial immunity, which would mean that they are getting sick, but asymptomatic, or it might be more complete immunity than that. So there might be a part of the population that's not ever getting sick. I'm going to end on this slide with links in it. They are very helpful videos or sites that I used as I put this together. I think one thing that kind of shocked me as I did this is that it's actually quite easy to find out exactly what you should be doing and when you should be going under lockdown, what you should do to come out of lockdown. This information is available to decision makers in both countries and to individuals if they want to find it. And the fact that a country like Congo, with all of its problems, took the time, took the leadership to follow these guidelines and protect their population is commendable.